Hi, everybody. Thank you for joining us for today's Flex EMS Supplement Cohort webinar. This is the first webinar of the second year of your projects. And today we are going to talk about new National EMS Quality Alliance measure sets, or so NEMSQA is going to be our speaker. And the presentation is Tools for EMS to Operationalize Evidence-Based Care. Talia, before we get started, did you have any announcements or things that you wanted to give the group before I introduce our speakers?
Just briefly, just a couple of reminders for everybody that your end of year reports are due November 30th, and then carryover requests, that if you are interested in carryover requests, those are due December 29th. Remember to make a note of that in your FFR. And also if you haven't already spoken with me about your idea for a carryover request, it would be best to do that probably within the next 2 weeks so that we can get that talked about and figured out for you, so you can be well on your way for all the forms and whatnot that you have to fill out. That's all for me.
Thank you, Talia. So with that, I don't really have any announcements from the task perspective, so I'm going to just go ahead and introduce our speakers. So we have Cherie Murphy and Dr. Jeff Jarvis. Prior to the role as Executive Director for NEMSQA, Cherie worked 15 years at the American Heart, American Stroke Association in their healthcare quality programs, Get With the Guidelines and Mission Lifeline Systems of Care. She also worked with FDNY and NYS DOH, so that looks like New York State to me, to implement STEMI and stroke systems of care. She also volunteered as an EMT in a volunteer fire-based rescue squad in upstate New York. Dr. Jeff Jarvis is the Chief Medical Officer and System Medical Director for the Metropolitan Area EMS Authority in Fort Worth, Texas, also known as MedStar. Jeff began his career in EMS 37 years ago as a volunteer firefighter in rural East Texas. He has worked in 3 states as a paramedic and maintains his active paramedic license today. In addition to his clinical practice, Dr. Jarvis has served as both the Texas State EMS Training Coordinator and the founding department chair of the EMS Professions Program at Temple College. He teaches extensively and has authored multiple articles on EMS issues in both peer-reviewed and industry journals. And his research interests include airway management and clinical performance measures. And with that, I think I am going to turn it over to our speakers and let them get started.
Outstanding. Well, thank you so much. And I really appreciate the very artful way that you basically said I was old. So I appreciate that. Well done. So I was just over on my left. I have a TV up that has all of the news stations on it. And if you've looked at the news lately, you won't see a whole lot of really encouraging things. So I wanted to start off by giving you some evidence of something encouraging. Cherie is quite the New Yorker. I am quite the Texan. And we get along really well and work well together. So there is some hope in the world. Hopefully there's just a little bit of optimism for your day today. So thank y'all for having us. What I want to talk to y'all about is NEMSQA, who we are, what we do, and how we do it. So we are the National EMS Quality Alliance. And really our mission statement is to operationalize evidence-based medicine through guidelines. We want to take the science and operationalize it into a way that the street level providers know how to take that evidence and translate it into patients. So here is a rough idea about what we're going to talk about. I want to give you an idea of who NEMSQA is, go over our measure development process, talk about endorsement, talk about some of the things we've done, particularly about what our measures are, and then give you some resources and talk about what is next. As we go through here, there are some partnerships that I want to mention, and I want to just thank these folks to begin with. We've done some wonderful projects with the state of Florida with their EMS office through their FAIR project. Florida has been wonderful partners for us. The ACS, the American College of Surgeons, specifically their their Committee on Trauma, so ACSCOT, has worked on some measures with us, and then NEMSQA, which is the National Association of State EMS Officials. These are the state directors, the state training coordinators. We are currently working on a grant with them to produce evidence-based airway management guidelines and measures for that. So we have some wonderful partners, and we've really benefited from that partnership. All right, so what is it we do? There are really two basic things we do. Number one is we build performance measures. Specifically, there's some benefit for nerds like me in measurement for measurement's sake, but that's not really where the strength of measures are. Really, measurement is just a tool to help improve the quality of clinical care. So that's what we want to do. We really want to focus on identifying those measures and creating ways for EMS agencies to measure them. So that is what we do. All right, so why does this matter? EMS historically has had one and only one performance measure. So EMS is about 40 to 45 years old now. Oh my, I'm doing math. That's not quite right. About 50 years old. EMS was officially born in 1966. So it's 1 year older than I am. And since that time, up until really the recent past, the one measure of a quality EMS system was response time. How quickly did you get to the scene of an emergency? And while that is important in some cases, the vast majority of cases, what is far more important is what you do when you get there. So there just weren't any measures of the things that matter clinically, and we wanted to provide those. And that's really what we're doing here. So let's talk about some NEMSQA history. There was a federal effort that was underway prior to our onset. That was called EMS Compass. And it was the first take at building EMS performance measures. And they built a set of around 12 to 13 measures. But there were organizational and operational challenges with really disseminating those and then nailing them down and using a high level of science, of measurement science in developing them. So NHTSA, the National Highway Traffic Safety Administration, in 2017 arranged a group to come and take another stab at that. We, in 2018, formed our organizational structure. We established ourselves as a 501c6, not C3, C6. And then we had been doing, in the 2 years prior to that, taking those existing measures, identifying which ones we could validate, and applying a little bit more scientific rigor to them. And we were able to release those in 19. Obviously, the planet stopped rotating in 2020 because of a little virus. Despite that, we're able to roll out the measure set that also included all of the pseudocode and the technical specifications on each one of those measures. And we entered into this FAIR project with the state of Florida. Over the next 2 years, we worked on those, and it will go a little bit through the process and what the outcome of that was. But that was a very extensive process to expand out the available measures. In 21, we updated our management structure, and then we really started in on the second primary goal of NEMSQA. So I've been talking about measures so far, and most of what I'll talk about today is measures. But the second objective and the second goal of NEMSQA is quality improvement, using those measures to enhance care. And we started up this EMS quality improvement partnership. That really took root last year in 2022, finishing up early this year, when we embarked on the Lights and Sirens Collaborative. The Lights and Sirens Collaborative was the first ever national EMS quality improvement effort, and it was built around two NEMSQA measures, Safety 01 and Safety 02. And those are Safety 01 is the proportion of 911 responses to a scene that is made without using lights and sirens. So this is a safety measure. We know lights and sirens increase the risk of collision, injuries, and they add very, very little to the clinical care of a patient. So this initiative was designed at making responses safer. That Safety 01, Safety 02 is exactly the same measure, but going to the hospital. So that was going on. In addition, in 2022, we worked with ACS-COT, the American College of Surgeons, to revise some of our guidelines around getting trauma patients to the correct facilities. And then this year, we have released our expanded measure set. Most of those, actually, I think all of those were from the FAIR project. And we embarked on building the airway evidence-based guideline measures. We're out validating those right now, and we are working with the Pre-Hospital Guidelines Consortium on identifying the evidence for our next round of measures. And we'll talk more about that in a bit. So let's go over, when we talk about measures, let me give you an idea of what these measures are. So this slide is a little bit out of date. These are no longer current measures because several weeks ago we released the enhanced set. These were the measures that we've had for the last several years. You can see the measure ID and then a brief description of what they are. They cover metabolic emergencies with hypoglycemia, pulmonary or respiratory disorders, talking about assessment of respiratory disorders and treatment of bronchospastic disorders. We had one specific pediatric measure that says, how often are you measuring the weight of your pediatric patients? This is particularly important because almost all medications for wee ones are measured on a per kilogram basis. If you don't know the kilograms, you can't get to the right dose. So we wanted to look at that. Some neurologic measures around treatment of seizures and assessment of stroke. We have some trauma measures geared around assessment of pain and treatment of pain, as well as getting hurt people to the right hurt people hospital. And then the safety measures that we talk about. So let's get a little bit into the FAIR measures. And I can't help myself. I always talk about FAIR in Florida, and I just push it together as FLAIR. So the FLAIR.
Hey, Jeff, can I interrupt you for 1 second?
Absolutely,
I am
please.
so sorry.
Oh, no worries.
Before we get into this topic of the actual measures, I just want to ask everybody just a couple of questions so we can kind of quickly gauge a little bit of knowledge gain after this, after you present the content. So the first question is concerning your knowledge of NEMSQA, so all of you as participants, and the work that NEMSQA does to promote a culture of quality improvement. How confident are you? So go ahead and choose one of those options, from extremely confident to unfamiliar. And then the second question is concerning your knowledge of rural EMS quality improvement initiatives that could be implemented in your state. How confident are you? And once we just get a couple of responses to that, we'll get rid of that. We'll ask the same questions at the end and just get some idea of what people are taking away from this presentation. I'm so sorry to interrupt you.
Not at all. I love it. See, what you're doing is measurement, and I'm a measurement nerd, so I think this is wonderful. I like to see improvement.
Go ahead.
So thank you. So FLAIR, the Florida the Florida measures, this was specifically a grant to build out measures for rural areas. And as you can probably figure out, the physiology around medicine doesn't really change much if you're in a rural area or an urban area. Patients are patients, physiology is physiology, but the way that you provide care in urban areas there are a lot more challenges than there are in urban areas. So because of that, not all of the measures that we developed for those rural areas were directly applicable to urban areas, but there was the Venn diagram was pretty good. There was a substantial overlap. All right, so let's take a look at the measures that we developed for, oops, my computer is having a seizure. Perhaps I could measure the treatment of my computer seizure. So here are the FAIR measures, and I don't really want to go through all of them, but there are a substantial number of them. Some of these measures are stratified. So as an example, my favorite of all time, because I'm an airway nerd, is Airway 01, and this is the successful first pass success with an invasive airway for a patient without creating hypotension or hypoxia, so low blood pressure or low oxygen level during the attempt. And specifically, it's 5 minutes before and 5 minutes after. substantial amount of evidence that this really matters clinically. Failure to do this is associated with some badness, and we don't want to do that. So that is one measure, but it actually has 6 stratifications. So we stratify by the type of invasive airway. So we have one stratification for all invasive airways, one for intubation only, one for supraglottic airways, and then each of those 3 groups, all intubation and supraglottic, we further stratify by age. And those are basically adults and pediatrics. So as you look at this, you'll see the number of stratifications and what they're stratified by. So we have a substantial number of airway measures, very exciting to see that. Some cardiac measures, some cardiac arrest measures, some environmental measures, and some sepsis measures, a lot of sepsis measures. So those are the FAIR measures. Now let's talk a little bit about the process that we use for developing measures. Now, there's a substantial body of evidence of the science about how you go through and build out these measures, and we adhere to that process. In general, I know this can be a fairly busy slide, but the concept I want you to understand is we start with an idea for a measure topic, and then we go out and we do this environmental search. Are there any measures out there already? If there are, we send them over and say, hey, let's think about whether this is something we should endorse or not. And if there's not, we say, okay, well, maybe we should build them. And we move down into the building process. That building process starts with looking at what the evidence is and coming to a conclusion about, does this matter and is this something that is worth measuring? If it is, we then look at whether it is feasible to measure, and we look at all of our measures right now are using something called NEMSQA. And I apologize if y'all understand this, and I'm going to tell you, so if I'm going over stuff you already know, please pardon me. NEMSQA is the National EMS standard. It is essentially a group of data definitions and a data schematron that all EMS agencies, or like 98% of EMS agencies in the nation, when they do their charting, it adheres to that schematron. So there is a massive data set, and we use those data definitions to build our measures. So all of our measures can be run on that data set. And that way, when you're looking at apples, you're not looking at comparing them to oranges. It's a good comparison. So if we can build them, then we will go out, build the technical specifications, and we start in with a validation process. We will run those measures once we've built this out. We'll run them against the NEMSQA data set and some other data sets, and then do some statistical testing on them to see if they are reliable and valid. If they are, we bring that testing information back to the committee. The committee reviews it and decides which measures to recommend for adoption. Once we have recommended them in the development committee, we forward those recommendations to the full board of directors, and then they vote on which ones to approve. So that's the development process for new measures. If there is, when we did our environmental survey, if we come across measures that are already in existence, we don't really want to reinvent the wheel. So we go through an endorsement process in which our committee evaluates several different criteria on each one of these measures. And what we're trying ultimately to do is decide whether this is something that is a good fit for NEMSQA. So as we're doing it, there are a couple of criteria, and I'll just run over these real quick. Number one, is this a high impact measure from a clinical standpoint? Remember, these are clinical measures that we're looking at. So does it matter clinically to our patients? We also look at the evidence. Is this evidence-based? Is it supported by the evidence? Now, there's an entire other science out there about how you grade and evaluate the evidence. And what we recognize is our skill set is around building measures. Our skill set is not necessarily around doing those formal systematic reviews. Fortunately, there is an organization out there that we work closely with called the Pre-Hospital Guidelines Consortium, and that is their expertise. and they have put out quite a few systematic reviews where they evaluate the evidence. When those exist, we take those and just say, you know what, we're not going to do all of that work again. They've already done it. We will take their level of evidence and evaluate them. Now, this is for measures that we're evaluating from somewhere else. Our goal after, say, the first 5 years of our organization, when we had this initial data set of measures we needed to build, is to take the recommendations of the evidence from Pre-Hospital Guidelines Consortium and use those as the basis for our measures. All right, so we look at the impact, we look at the evidence. We also look at the feasibility, which is just, does that data exist in NEMSIS? And is it reliable enough for us to turn into measures? We then look at the face validity. In essence, when you just look at this on the surface, does high performance on this measure relate to good quality care? So that's the value judgment that we ask people to make when we're doing this evaluation. And then finally, we look at, well, how much work is it going to cost? Cost, as Sheree nods her head. How much is it going to cost and how much work is going to go into doing the technical work on it? Some measures come with their own pseudocode. This is the code that translates the data values in NEMSIS into the measure. For the Florida measures, those didn't exist because these were new measures. So something we have to do all of that work on, a lot more work involved. We might prioritize that down just in terms of, say, a Pareto chart where you get the biggest bang for the least amount of work. That's what we're trying to see. And then we look at the endorsement, so or the ease of endorsement. So if there is a measure out there that has all of this, how likely is it that we're going to be able to reach an agreement on endorsing that measure and get an agreement worked out with the measure steward? In other words, the organization that owns the measure. And our goal is to see how easy it is to do that in 3 months. All right, so what is the down arrow key, not the forward arrow key? Here we go. What is our measurement cycle? So to give you an idea of where we've been, we started off on this next endorsement, or the first endorsement cycle, as opposed to the first development cycle. The first endorsement cycle really started about 1 year to 2 years ago when we did that environmental scan and said, what are all of the measures out there in existence from other organizations that might be valuable for NEMSQA to endorse? We came up with 174 of those. Our first review narrowed that down to 38. The vast majority was because of the ones we excluded. We excluded because they were not relevant to EMS, or they were relevant to EMS, but they weren't based on data that was available in NEMSIS. So then we ended up with 26. We went through another round of review where we applied those criteria, those 5 criteria that we talked about, to each measure, and we graded them A, B, or C. And I'll show you what those A, B, or C's mean in a bit. From those, we identified the measures that we really liked, and we reported those back to our board. Well, they were fair measures. Now, we happen to know already that these are evidence-based, they're reliable, because we had done all of the statistical testing on that. We recommended 11, we meaning the committee. The board adopted 10 of those. This year, we worked out the agreement with Florida. And again, Florida has been an absolutely amazing partner in this journey. And then several weeks ago, we published the new measures. The criteria we graded them on, this is part of our Delphi process. We're trying to evaluate the 38 measures, trying to get them down into which ones we should prioritize. We really looked for the things that were high value, so a big clinical impact, that were easy to endorse, great partner to work with, and that all of the work was already done on them. So those were the A-level measures, and here are the new measures. My favorite one right there, Airway 01, got adopted. So that's the successful first pass without hypoxia or hypotension. And you can see the other measures that we adopted. So for all of these measures, there are a couple things they have in common. All of our measures at NEMSQA have to be for EMS responses that originate from a 911 request for service. So what that means is EMS does 911 calls, emergency responses, as well as interfacility responses. Our measures right now look only at 911 responses. Let me try that. And then we stratify these by age. So if you look at our list of measures and you are very interested in pediatric care, you may be gravely disappointed to see that we really only have one dedicated pre-hospital pediatric measure. But fear not, all of our measures are actually pediatric measures because they're all stratified by age. So there are pediatric measures in here. All right, to give you an idea about what is next, we're going back and weighing or leaning against our partners at the Pre-Hospital Guidelines Consortium to get a list of all of the recommendations from their evidence-based guidelines. That is easily a 4-digit number. We are going through all of those. I think they're like just under 2,000 of those. We're looking at all of those recommendations and going through the process that we just discussed. How many of these are feasible? How many are applicable to EMS? That type of thing. And then those recommendations we're going to take and plug in at the beginning of our next measurement development cycle. All right. Now for the stuff that I really enjoy, which is seeing you have these measures developed, how do they perform? And most importantly, where are the areas that we can focus on for improvement? Well, this is some data from Biospatial. Biospatial does data collection, analysis, and monitoring with somewhere around 50% of all states. And you can see that some of these measures, these are some airway measures right here, have an awful lot of room for improvement. And if you look at these first 6 blue lines, all of which are under 35%, these are those, that Airway 01 measure that I like so much. And this is very critical to good outcomes for patients who have respiratory failure or an inability to protect their airway. And as you can see, we're not doing very well on this. And that means as an improvement guy, that's very exciting because that's where we can focus. Here are some of the other measures. If you look at Trauma 08, that's the big gray towers in the middle. That is documentation of vital signs and your assessment. I'm not that interested in improving that because we're already performing really, really well on it. So I really look for this, I guess you could say, is an inverse Pareto chart. We want to see where the worst performance is so that we can really focus on improving it. Here are some of the, let's see, these are the, I went the wrong way, didn't I? So that's how we're performing on measures. Now, the last thing I want to say is if you want to know the details about any given measure, well, like how do you define first pass success? How do you define hypoxia? All of those things, the things that are necessary to accurately measure your performance and compare it to another agency's performance using these measures, those are all available in the technical specifications, and those are available on our website. Now, if you want more information, you can just scan this QR code. And what I will tell you is we really want lots of people to get involved with NEMSQA to help support this effort. Sure, we like the financial support, but we really, really like the intellectual support. The more people we can get involved in this effort, specifically from as many diverse backgrounds as possible, allows us to do a better job of operationalizing the evidence. These are, this is how you can follow us on all of the socials, including the platform formerly known as Twitter, and how you can get a hold of Cherie. She is our executive director, AKA boss and miracle worker. And that is the information I have for y'all. So with that, I'm going to stop sharing my screen and open it up for any questions. So I actually have a question first, and
Sure.
that is, can you, I am still sharing, right?
There you go. Yep, now you're not. You're good
All
now.
right. That was my question. See, I had an easy question to get started.
Yours was easy. There was a question in the chat. Jill, did you want to unmute and ask?
Sure. So is CMS involved in the selection of these measures, or is it just, your agency that selects and hopes that everybody reports on them?
Sure. So CMS is not involved. And just from a description standpoint, individual agencies like EMS agencies can certainly be a part of NEMSQA, but NEMSQA is an association supported by larger associations. For example, I'm the representative from ACEP, the American College of Emergency Physicians. We have other representatives from other agencies that form NEMSQA. A big part, and as I think about it, I probably should have mentioned this, a big part of developing our measures is public comment. So this really is a community effort to identify which measures we use, but there is no federal involvement with this from CMS. The federal involvement was NHTSA helping get this undertaking underway.
Okay, thank you.
Mm-hmm.
There's another question in the chat. Andrea, did you want to ask your question?
Sure. Yeah. Hi, Dr. Jarvis. We are deep into our project work. And one of the things we've been looking at is when we pull data, we review the unknowns and the low percent trues, and we've been looking at the front and back end setups. So do you have any recommendations for making sure boxes are turned on in the right places on the front or back end of vendors?
Yeah, Andrea, this is a critical question. So you're clearly familiar with how NEMSIS works and where the data comes from. So it comes from the ESOs, the image trends, the EMS charts of the world. And each one of those platforms is different. They have different what the screen looks like when, as a medic, you're pecking away and putting the data in. And then there are different validation rules. Clearly, NEMSIS, each state has validation rules that you have to pass, as does the data center in Utah. I say it's in Utah. Who knows where the cloud actually is, but the cloud is everywhere. You have validation rules that you have to run there too, but that still leaves an awful lot of variability, and you're absolutely right about that. So when you look at some of the measures, and I'll give you a good example of this, the hardest measure I think we have is the appropriate treatment of patients with status epilepticus. And the reason for that is there's not a really clear box for active seizure in the NEMSIS data set. None of the vendors have it. And it's just because it doesn't exist in NEMSIS either. So we have to try to get decent surrogate measures for their actively seizing. And that's tough. And when you look at that performance, it's one of the lowest ones we have. So the challenge with this is there are a couple of routes that you can go with dirty data. And EMS, our data is pristine compared to all of the other data in the world, and it's still pretty dirty. So I think we're far better off than everybody else is, but we still have a problem with dirty data. So the catch is what do you do with that? You have two choices. Choice number one is you can throw your hands up and say, well, this is not an accurate reflection of the performance of the individuals. We're only going to start measuring once the data is an accurate representation. So that's option number one. Option number two recognizes that option number one ain't never going to happen. And it says you can't measure and improve on the data you want. You have to measure and improve on the data you got. And what we have found is that the first step in improvement, so for example, one of the big lessons we learned in our first quality improvement initiative with the Lights and Sirens Collaborative is how do we go about improving the accuracy of the data? So when I mentioned we really like diverse viewpoints, vendors are an important source of that. So we work with the EPCR vendors. We work with the folks in NEMSIS, with Dr. Mann and his colleagues. And we said, look, we have a problem getting this data. How can we improve this? Because the first step in most improvement efforts is to improve the data. So I think that what the point you're raising here is a really, really important one. And that's really, how do you improve the quality of your data? And I'm a big believer that the way to improve is to start improving. So you got to start from where you are, not where you want to be. With that said, the other thing is Steve McCoy, who's the state EMS director in Florida, who's been our partner with this since we initially started with FAIR, has really been pushing the concept of coming up with measures of data quality. So all of our measures really are clinically oriented. Well, that's one that would cross all measures and say, well, what is the overall quality of an agency's data? And then one of the performance things for your agency, so you know what, your data quality isn't very good. The challenge is that's probably one of the most difficult measures to do, and we are still trying to find out the best way to do it. But that's absolutely something we're looking at. So Andrea, that's a really important question. Thank you for asking it.
Yeah, thank you for the answer. And interestingly, our seizure category is the lowest percentage. So I'm glad you mentioned that. That makes me understand why.
It's also clinically hard. So well, I'll tell you what, I won't dive too much into the clinical problems with it. But it really is, it's probably the best measure we have on seizure management. Tons of evidence that says giving benzos for seizures is the right thing to do. We just got to really get to work on the quality of the data.
Perfect. Thank you.
Yes, ma'am. Thank you.
I think I can confidently say too, from, this is the second multi-year supplement that FRHP has done in recent years involving data. The last was a 3-year supplement, and some people chose to do data-related projects. This one, there are 6 states that are all doing data-related projects, and I don't know that any of them got into their projects and were like, oh, look, our data was great. I think that a lot of times they're very surprised, maybe not this group as much, because I feel like this group, being that they're all focused on data and there's a lot of partnership with their state office of EMS, or state offices of rural health have brought in EMS expertise like Andrea. Those people they know going in that they're not going to be surprised to find data quality issues. I remember working with Steve McCoy in year 1 of the last 3-year supplement, and he was like, I was a little bit surprised at how bad the data is going in, and now I know he's been, nothing but that going forward. Right. And so I think every data project that at least our flex programs have done, they've been a little bit surprised to find out how bad the data quality is going in. I know if our New Mexico people were here, Donnie Roberts would be, you are preaching to the choir. That's exactly what he does. And that's been ongoing. It hasn't gotten better. It's something that is just an ongoing focus, is making sure that data going in is good, and they're catching that right away, that there's problems with the data and not just assuming that it is good.
I do a lot of, when I do research, I do my own data analysis because, I may have mentioned I'm a nerd. And so I do data analysis for fun. That's the kind of jerk I am. I really enjoy that. But when you look at data science and talk to data scientists, they'll tell you 65 to 80% of their job is cleaning up data. Clean data just doesn't exist. That's not. If you see clean data, it's not real data. I
suspect that's a problem.
Yeah, exactly.
Don't believe it.
Yep. Our problem is we have to deal with humans.
Yeah. Any other questions anybody has for Jeff? Okay, I just wanted to reiterate a little bit about the Flex program and the rural EMS program area. I haven't been able to dive into grant documents for a few years to find out exactly what it is that Flex programs are doing. I can tell you what they could be doing. The EMS program area of the Flex program consists of, first and foremost, assessment. So it's either a state level assessment or community level assessment. One of the two has to happen. And then the other 2 parts of the program area are operational improvement. So operational improvement or quality improvement, one or the other, or both. So I think STEMI, stroke and trauma have definitely been very common focuses over the years for Flex programs. They've kind of moved away from it into other things, or are doing it differently, but trauma designation and such have been big. establishing criteria around the appropriate hospital for transport is not as common, but it is something they could be doing. Transferring patients and pre-hospital activation, those are things that they could be doing. This one I think is definitely gaining ground, technical assistance for data reporting to NEMSIS and the state level quality reporting systems. And you talked about how NEMSIS is so widely accepted. We educated this group about NEMSIS in the first year, and that was very well received. The state offices of EMS know who NEMSIS is, but our flex programs and our state offices of rural health are a little less familiar. So that was well received information. Training and technical assistance to support performance improvement so not just reporting, but also improving. Encouraging critical access hospitals and EMS agencies to collaborate in those trauma events, EMS quality improvement networks, those sorts of things are pretty commonly accepted and things that happen. Oh, hi, Donnie. I see you are there. Did you have any? I didn't know you were here. I apologize. Did you have any questions or comments for Jeff or any of this conversation? I really expected to hear from you talking about data quality. Maybe not. So I just wanted to give you, Jeff, a little bit of background about the Flex program. EMS is an optional program area. People do not have to opt into it. Last count, roughly half were opted into it. It seems like it gains some ground every year. So that's it. Unless anybody else has any questions for Jeff or Cherie. Thank you so much for joining. It was really interesting to hear. We have our post-polling questions. Thank you, Caroline, because obviously I can't remember a darn thing. Answer these couple of questions so we can figure out the quick and dirty knowledge gain from what Jeff just told us about NEMSQA measures and the FAIR project. And
so I just answered mine, so I just figured I'd go ahead and skew your data. I'm sure
thank
Cherie
you.
did too,
Now my
so
data is dirty. Dang it.
one more reason to use median and not mean.
Oh my goodness.
Non-parametric data. I love it. Well, thank you very much.
Yeah, no, thank you so much for joining us. This was fantastic. And now when I need a data nerd, I know who to reach out to. Yes.